So this is the internet not loading? I mean, no. You really don't have to be quiet. What you really doing?
Are you cold? Did you get wet? Coats or come in. Tell your brother that's the same thing.
Seems like Mono's going to great. Little kids have had Mono. It's a couple of or 7th, 8th grade or something. Never seen Mono go around. There's like some little bitty kids. Yeah.
Works right ordinary, better. You appeared on here while you were in there. Is that what you were looking for?
Yeah, but
Now he's in the back. You have to be quiet. Hey, I was telling your brother, if you have snow ice running out of your nose, then that means that you need to cover your arms and your. What? No, like that.
It says locked.
I don't know why we're not getting
Are we supposed to
volume.
be filling up these?
Okay, I don't know why we're not getting volume. I don't know if you guys could hear me. But tonight I was going to do this OTEP thing, and I guess when I was moving, it's playing in there.
Yeah, I can hear it in there.
The internet sucks so bad here, it won't play over. Unfortunately, you know what I might do, I guess, is I could shut this computer down. We could just go in there and watch it on that computer. So Kim, I don't know if you could hear me or not, and I don't know if you can see the video. If you can't and it's blotchy, just stop and don't worry about it. Don't worry about watching it. But what we're going to do is we're going to watch this OTEP video, which is just the right person, right place, right time. And then I'll talk about it. So if it's blotchy and it's not actually playing, like it's not on this computer, then check back in about, I would say, I think it lasts like 30 minutes, 20 or 30 minutes. So we're going to watch it. But for right now, I'm going to log. I guess I can't really drop the call. Continue broadcast. So I can't drop the call, but we're gonna go in there and watch it on the other room. Let's just go in there and watch it. I had it resting on my computer and I moved it out of my trash and it was. Kim, it's 24 minutes.
You gotta get the fuck out of the way.
Variety of resources, from basic X-ray and lab capabilities to highly sophisticated surgical specialties. Transporting a patient to a suboptimal facility can result in longer treatment times, leading to death, dismemberment, paralysis, and a host of undesirable outcomes. Establishing triage criteria for both primary and secondary patient severity levels ensures uniformity in the prioritization of injured patients and provides a common language for the trauma system. Oklahoma. It's not always possible for every Priority 1 seriously injured patient to be primarily delivered to a Level 1, 2, or regional Level 3 because of time and distance from the site of injury. If time allows, it is best to bypass lower-level trauma centers in order to deliver the seriously injured patient to a facility capable of providing definitive care. When it is necessary to deliver a seriously injured patient to a lower-level trauma center, it is imperative that only essential stabilizing care be provided before secondary transfer. It is not in the seriously injured patient's best interest for time-consuming diagnostic tests to be carried out if the facility does not have the necessary resources to care for the potential abnormal results. The performance of non-therapeutic diagnostic testing should be avoided, as it will delay definitive care. Ground EMS should consider the use of air rendezvous at the scene or lower-level trauma center if weather permits in order to expedite transfer to a higher level of care. To get the timely treatment they need, Oklahoma is divided into 8 trauma regions. Each region has unique resources and its own distinctive plan for delivering critical care. The regional plan is based on the availability of acute care at the hospital level. Let's take a look at Oklahoma's trauma center designations. Throughout the state, hospitals are divided into 4 trauma care levels. Level 1 and Level 2 centers provide all aspects of patient care. They offer surgeon-led trauma teams for immediate surgical intervention 24 hours a day. Level 1 and 2 facilities offer rapid availability of specialty services, including cardiovascular, neurological, orthopedic, maxillofacial, and others. Additionally, Level 1 facilities provide research and community outreach programs. Level 3 centers are capable of handling minor to intermediate trauma, including most Priority 2 and Priority 3 injuries. They operate around the clock with at least one physician in the emergency department, a nursing staff, and both general and orthopedic surgeons immediately available. Level 3 centers provide prompt anesthesia, X-rays, and lab services. Designed for mild to moderate trauma, these facilities can stabilize Priority 1 victims for transport to facilities with the capability and capacity to provide definitive care. Occasionally,
No,
level 3 centers
man.
can be regional level 3 when enhanced services such as neurosurgery are available or on call. Level 4 facilities are designed for rapid stabilization and referral of seriously injured patients. They offer 24-hour availability of at least one of the following: licensed physician assistant, nurse practitioner, registered nurse, or paramedic with specialized trauma training. Priority 3 patients may be safely transported to and receive definitive care at a level 4 facility. Let's take a minute to discuss trauma center designations and their importance to patient care. Your grasp of trauma center designations is crucial to saving lives. Now that we understand these classifications, let's explore the pre-hospital trauma triage guidelines for EMS workers. This booklet contains a pre-hospital algorithm and a detailed explanation of patient priorities. The word algorithm may sound complicated, but an algorithm is nothing more than a step-by-step protocol guiding your decision-making in the field. The Oklahoma trauma system provides separate algorithms for adult and pediatric patients, but significant commonalities exist. Based on your observations, the algorithm suggests the appropriate course of action for stabilizing and transporting patients. These simple one-page flowcharts will help you save lives. It's also crucial that you fully understand patient priority criteria. Rapidly assessing patient criticality is important for several reasons. For starters, it allows for rapid coordination between hospitals and EMS workers to determine the patient's destination. Remember, the closest facility isn't always the right facility. The better you are at prioritizing patients, the better their outcomes will be. Priority criteria also help determine the need for air transport and ground-based advanced life support intersect. Finally, prioritizing prevents over and under triage into level 1 and 2 trauma centers. This addresses patient needs without overtaxing the resources of higher level facilities. With that in mind, let's examine patient priority criteria. Priority 1 or P1 patients are the most critical you will encounter. They exhibit high-energy blunt or penetrating injuries causing significant physiological abnormalities or significant anatomical injuries. Multi-system injuries are common. P1 patients should be transported directly to level 1, level 2, or regional level 3 facilities if possible. If time and distance do not allow delivery to a higher level trauma center, Air Rendezvous can be a lifesaver when dealing with these critical patients. Priority 2, also known as P2 patients, are more stable, not as time sensitive, with less severe injuries than Priority 1. P2 patients exhibit no physiological abnormalities or significant anatomical injuries that are potentially time sensitive in nature. Typically, these patients can be safely transported to the nearest facility with the resources to perform a trauma evaluation and provide adequate care for their injuries. However, in some instances, P2 patients may exhibit significant single-system injuries. These time-sensitive injuries should be treated with urgency, and they should be transferred to a facility with the appropriate on-call specialists to care for the patient's injury. Priority 3 patients generally have been involved in a low-energy event. They present no physiological abnormalities, altered mentation, or neurological deficit, and no significant single-system injuries. Priority 3 patients are the least acute and can be safely transported to their hospital of choice or to the nearest appropriate facility. Let's pause here for a short discussion about the patient priority system and pre-hospital algorithm.
Blah, 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 short discussion, blah, blah.
Now let's turn our attention to TREC and the TREC Quick Reference Guide. These resources are designed to help doctors, nurses, physician assistants, and nurse practitioners facilitate secondary triage and interfacility transfer of critical patients. They can also help transfer patients with single-system injuries requiring specialized care, such as eye and hand injuries. What exactly is TREC, and how can it help your patients? The Trauma Referral Center, or TREC, is a statewide hotline that acts as an information clearinghouse and transfer center. TREC's mission, in part, is to get time-sensitive patients the care they need and to preserve high-level resources for the most acute patients. It expedites the interfacility transfer of patients to the nearest appropriate facility. In order to work effectively with TREC, all ER personnel should be familiar with the TREC Quick Reference Guide. This booklet will help you make rapid assessments of both adult and pediatric patients and establish the appropriate patient priority. The guide also covers system and mechanism-specific injuries, including thermal burns, hand injuries, maxillofacial trauma, and obstetric issues. Using these criteria, you should be able to rapidly assess patient criticality and report your findings to the TREC dispatcher. How can the TREC Quick Reference Guide help you? Say you've got a pregnant P1 patient with non-reassuring fetal heart tones or a significant orthopedic injury. How would you react? The Trek Quick Reference Guide provides rapid guidance on these and other scenarios. Central to Trek's mission is a tool known as EM Resource. This amazing IT tool is revolutionizing emergency trauma care. EM Resource streamlines patient transfers by monitoring critical assets, ER capacity, and on-call physicians by tracking the availability of specialists statewide. In combination with hospitals around the state, Trek utilizes EM Resource to ensure prompt destination decisions for your patients. This keeps patients as close to home as possible and prevents over-triage into Regions 7 and 8. EM Resource is a robust tool for transferring patients throughout the state. Why should you use Trek to transfer your patients? Consider this. Definitive care facilities do not have the option of turning down patient transfers if they have the capability to care for your patient. Therefore, Trek eliminates the need to doctor shop, saving hospital staff time and reducing mortality for critically injured patients. If you need help classifying the patient, Trek can talk you through it if necessary. When you call the hotline, be prepared to provide Trek with the priority and geographic location of the patient. Trek will determine the nearest appropriate facility for transport. Transfer of single system injuries requiring specialty care can also be handled by Trek. To keep patients as close to home as possible and prevent over-triage into OKC and Tulsa, Trek utilizes a matrix located on page 19 of the Interfacility Trauma Triage and Transfer Guidelines in order to locate the closest appropriate specialist or hospital resources needed for each patient's care. Sending pictures of various injuries such as hand trauma can help specialists decide the extent of care needed, which also helps prevent unnecessary transfers. Remember, the closest facility may be overutilized or underprepared to meet patient needs. Therefore, it's not always the right choice for time-sensitive patients. Trek helps balance patient needs with available resources, including patient loads at the hospital level and the availability of specialized care. Once the destination has been finalized, Trek will transfer the caller to the receiving facility. Remember, anytime you transfer a patient, you should transfer all of the relevant documentation. That includes notes, exams, lab results, EKGs, X-rays, and any other diagnostic materials. You're the patient advocate, so it's important to keep track of these details, including written and digital documentation. Transferring documentation is critical, but it's equally important not to perform non-therapeutic diagnostic testing on severely injured patients. If your facility does not have the resources to provide definitive care for a P1 injured patient, don't waste critical time performing unnecessary tests. Non-therapeutic diagnostic testing is absolutely not in the patient's best interest. It prolongs treatment times and leads to increased morbidity and mortality. This is especially important for level 3 and level 4 facilities. If you do not have the resources to provide definitive care, immediately initiate a transfer through the Trek hotline. Working closely with EMS workers, it's also appropriate to initiate air transport even before the patient arrives if necessary. Let's take a short break to discuss Trek, the Trek Quick Reference Guide, and the importance of performing only medically necessary tests. So far, we've explored the powerful toolbox offered by Oklahoma's trauma care system. We've learned to use the pre-hospital algorithm, Interfacility Trauma Triage Guidelines, and Trek Quick Reference Guide to improve response times and decision-making. We've covered the essentials of the Trek hotline and the basic makeup of the Oklahoma trauma care system. Let's see how the big picture comes together, or doesn't come together, at the scene of a devastating vehicle accident. You arrive at the scene of a vehicle rollover on a remote stretch of highway. The driver, Tammy Martin, overcorrected after leaving the road. Riding unrestrained, she was ejected through an open window.
Ma'am, you hear me? Ma'am? She's breathing, she's unconscious. She's hurt pretty bad. Yeah, she's hurt pretty bad. We need to get community hospital ER on the line. Tell them we got a female patient involved in a rollover accident. Community hospital? That's level 2, 30 miles away now. We're scared of Quad City. It's level 4, but it's only 8 miles away tops. Quad City's medic 1.
Copy that, medic 1.
Quad City, we're going to be around to your location. One female patient, approximately 20 years old, been involved in a vehicle rollover accident. The patient's going to have possible internal bleeding, fractured ribs. She got lacerations to the head. possible head injury. Patient's going to be unconscious at this time.
Copy that. We'll be ready.
Unconscious female. Look too touching. Real low. Tammy. That side. Here on 3. 1, 2, 3.
What's going on, guys?
Got an unconscious female. Got involved in a vehicle rollover. Possible head injuries. Got internal bleeding. Possibly some broken bones. Blood pressure. What's your blood? That's 160 over 100.
O2 sat.
98% on O2.
So we have closed head injury, neck trauma, chest trauma. Let's go ahead and start ordering some labs, CBC, chemistry. Let's get a CT of her head, neck x-ray. Hello, this is Dr. Stanley at Quad City ER. Is this community hospital? I need to talk to your ER doctor, please. Yes, sir. This is Dr. Stanley at Quad City ER. I have a patient I'd like to transfer to you. She's had closed head trauma, internal bleeding. We've got CAT scan of her head, chest x-ray, abdominal CAT scan. She needs to see a trauma surgeon. Is there any way we can transfer her to you?
2 hours after arriving at Quad City's Level 4 Trauma Center, Tammy died of cranial hemorrhaging. She never saw a neurosurgeon.
Poor Tammy.
She's definitely a priority 1 patient. We need to get her to community hospital. That's pretty far. I don't think she'll make it. We need to get her somewhere to provide the care she needs. Well, let's get her stabilized. Her airways are very secure. Let's get her running up. Unconscious female. Look too touching. Real low. Tammy. Side. 1, 2, 3.
What's going on, guys?
Got an unconscious female. Got involved in a vehicle rollover. Possible head injuries. Got internal bleeding. Possibly some broken bones.
Blood pressure, what's your blood pressure?
That's 160 over 100.
O2 sat.
98% on O2. I can't get information.
Sounds like we need to establish an airway. Let's go ahead and call Trek. We're going to have to transfer this patient.
Okay.
And guys, we need to have you stick around here.
Trauma referral, can I help you? This is Jennifer Johnston at Quad City ER. We've got a priority 1 crash victim with cranial injuries, broken ribs, and possible internal bleeding. She's unconscious and needs immediate definitive care that we cannot provide here. We're stabilizing her now. Okay, I can help you with that. How old is your patient? Is she hemodynamically stable? It looks like Lincoln General is going to be covering trauma for your area. So if you will stay on the line for me, I'll get their ER attending on the phone and we'll get your patient taken care of, okay? Okay. Dr. Stanley, they're connecting us with Lincoln General Hospital. Hi there, it's Lindsay at the Trauma Referral Center. I have a physician on the other line from Quad City ER that has a 25-year-old female that he's needing to transfer to a higher level of care. Can I put him through to you? All right, thank you. All right, can I have you on the line with Lincoln General?
Hello, this is Dr. Stanley. Yes, we have a patient that's 22 years of age. She's had closed head trauma. Guys, are going to go ahead and transfer her to Lincoln General.
A short time later, Tammy arrived at Lincoln General. She got specialized care from the trauma team, including the neurosurgeon, and miraculously, she pulled through. Had she stayed at Quad City for unnecessary tests, she wouldn't have been so lucky. This is just one example of providing proper care and transport for the patient. There are a number of factors to consider when getting high-priority patients to the appropriate facilities. Time, distance, and weather all figure into the decision-making process. For example, in the scenario you just watched, the EMS agency transported the patient to the Level 4 hospital because they could not secure the airway. Once the airway was secure, the patient was transferred from the Level 4 hospital to the Level 2 hospital via TREC. Had the patient's airway not been an issue, she could have been transported directly to the nearest Level 1, 2, or Regional 3 hospital. Direct transport or interfacility transfer to a level 1, 2, or regional 3 facility should occur as soon as possible for all priority 1 patients. If the priority 1 patient is stable enough for transport and time and distance allow, then the patient should be transported directly to the nearest level 1, 2, or regional 3 facility in the fastest, safest manner possible. If time and distance do not allow direct transport by ground to a level 1, 2, or regional 3 hospital, air ambulance transport should be considered when flying conditions are favorable, as it can improve the chances of a positive patient outcome. Air rendezvous at the CU or at the level 3 or 4 hospital should be considered. Basic EMS services should consider ground ALS intercept whenever they have an unstable, high-priority patient and air ambulance transport is not indicated or when it is not an option available to them.
Today, we examine the powerful, life-saving resources at your fingertips. We covered trauma-centered classifications and patient priority criteria. We also took a look at the pre-hospital algorithms, the Trauma Referral Center, or TRAC, and the TRAC Quick Reference Guide. These tools are crucial for saving lives and reducing morbidity. Your patients are counting on you, and it's your responsibility to act in their best interest. Oklahoma's trauma system has made incredible strides over the past decade, but we still can do better. The tools and resources we examine today will help you reduce treatment times, maximize regional resources, and ultimately to save lives and reduce disability from injury. It's all about getting the right patient to the right place, receiving the right treatment in the right amount of time. From all of us at the Oklahoma State Department of Health and the OU Department of Emergency Medicine, we want to thank you for joining us in this effort.
Your patients are counting on you, and it's your responsibility to act in their best interests. Oklahoma's trauma system has made incredible strides over the past decade, but we can still do better. The tools and resources we examine today are on the cutting edge of medicine. They'll help you reduce treatment times, maximize regional resources, and ultimately to save lives. It's all about getting the right patient to the right place, receiving the right treatment in the right amount of time. Thanks for joining us today. From all of us at the Oklahoma State Department of Health and the Oklahoma Institute for Disaster and Emergency Medicine. For further information, or if you would like to set up training with your agency or facility, please contact Oklahoma State Department of Health Emergency Systems at 405-271-4027. Special thanks to the Perry Fire Department, Perry Paint and Body, Perry Memorial Hospital, Perry Police Department, Dr. Michael Hartwig of the Perry Family Practice, EMSA East, the Trauma Referral Center, and Dr. Sakra.
All righty, let's do this. Well, it's not ours, is it? All right, I guess we're just gonna hang out in the office, huh? You get that.
Yes.
Oh, there it is.
And there's Nola.
Yep.
Lane, you're fun.
Hello.
Quit, back up.
Me?
No, everybody gets to see you and all your mustard glory.
Alright.
Couldn't see my anger match.
So, there are guidelines that we're supposed to use to determine the right patient, right place, right time. Oklahoma has their list, their guidelines. You can find it on the OSDH website. I usually print them off for you guys. You guys leaving behind and print them all in. I didn't print anything off. Plus, I kind of ran out of time. You guys do a fairly good job at finding it. I'm never going to get onto you guys for over triaging a patient and sending them by air. It's just not something I'm going to do. And I also am not going to jump on you for under triaging a patient. I'm guilty of that too. Go through a rollover accident and patient's fine talking to you and then get to the hospital and go down. My God. End up having a whole bunch of issues. So Plus, I'm leaving in January, so I'm not really going for anything. Go lay down.
Girl.
There is a push, though, from the state to reduce the number of patients that we're flying. They think we're overutilizing aircraft. I don't necessarily agree with them, but I do highly encourage you guys to at least take a look at what the trauma guidelines are. So you have priority 1 patient, and you start with, it has a little algorithm, so physiological compromise criteria. So hemodynamic compromise system, blood pressure less than 90, or signs that should be considered include sustained tachycardia, cool diaphragmatic skin, respiratory compromise, the respiratory rate below 10 or greater than 29 breaths per minute, or above 20 breaths per minute in an infant. That's infant to 1 year. Altered mentation or trauma etiology with a GCS of less than 14. If any of those are yes, that's a priority 1 patient. Make sure I'm using the adult one. Yeah, use an adult one. So any of those things, yes, please send them by aircraft. If no, you still have other things. And this is the big one. This is the one that they really seem to focus on, and sometimes they get it wrong. Penetrating injury of head, neck, chest, abdomen, or extremities proximal to elbow or knee. So anything that is above the elbows or above the knee that is a penetrating wound, they're calling that a priority 1 patient. It's pretty simple. You don't have, we don't have, right now we don't have the ability to tell whether that puncture hit anything. So combination burns, greater than 10% or significant burns involving face, airway, hands, feet, or genitalia without significant trauma. Transport. So if they don't have significant trauma, transport them to the burn center. Burns greater than 10% with significant trauma, transport to trauma center. So you gotta take care of the trauma first, stabilize, and then they'll go to the burn. Amputation above wrist or ankle is going to be a priority 1. Paralysis or suspected spinal fracture with neurological deficit, priority 1. Flail chest, 2 or more obvious proximal long bone fractures, upper arm or thigh. So if you have bilateral femur fractures, it's priority 1. Bilateral humerus fractures is priority 1. Humerus fracture, femur fracture, that's priority 1.
Go ahead, if you're hungry, eat another sandwich.
Open or suspected depressed skull fracture, unstable pelvis or suspected unstable pelvic fracture. That one kind of gets me. We run a lot of like falls, like elderly falls, where the hips are unstable, but their patient is completely stable. But that should be considered a priority 1 patient. Tender and or distended abdomen, crushed with gloves or mangled extremities. Any of those that meet your priority 1 patient. Then those patients should go to the appropriate level 1 trauma center or level 2. Let me see exactly what they say. Rapid transport to designated level 1, 2, or regional level 3 trauma center according to regional trauma plan, but may be stabilized at a level 3 or 4 facility depending on location and time and distance to a higher level trauma center. There's a few things to consider in there, and this is where, whenever we're out here in Western Oklahoma, the state, I think the state don't quite understand. Where's our level 1 at in Oklahoma?
Do what?
Do you know where the level 1 trauma center is?
OU.
Only level 1 trauma center is OU. Level 2. It's a
rotation.
It's a rotation, and it is the stupidest thing. I think that this
So
system.
you can go 1 and 2 for the day. You talk about a not happy place. If you don't have a legit patient.
I have issues, I guess, simply because I come from a system that you're either a level 2 or you're not, and we had 2 level 1s in the same city, 2 level 1s and a level 2 in Wichita. So one side of I-35 was Wesley, and the other side was St. Francis, and then you had St. Joe, which was a level 2 for a while, and then they dropped their level 2 status. All you had is level 1 trauma center. But I just think it's confusing and silly, and then it creates animosity between the receiving staff and the crews that are taking them in, because they're mad that, well, one, I've been yelled at whenever they thought it should be a level 1 patient, obviously wasn't, but they don't want these patients. They don't want level 2 patients. They don't like being on trauma day. And so there's animosity between them and the staff. Whereas if it was a dedicated level 2, your staff is ready to be a level 2 trauma center. It's not this one random day out of the month or week or whatever it is. And I just don't like the system. I think it's stupid. That's a soapbox. I'm trying to get off of it. Yeah, they always piss off when you any patient level 2. Yeah. Yeah, you're like, what makes a level 1? I had one that they told me there's a level 1 because they had abdominal pain. Well, she's touching his spine through the front of his belly. And she's like, he has abdominal pain. I said, yeah, because you're touching his spine. And so we just decided to walk out, and we left. And came back about an hour later to ask him, hey, what'd you find out about Josh? Oh, we released him. Couldn't find anything. Oh, so that should have been a level 1, right? But they don't want those patients. So that is kind of your criteria for priority 1. We're going over it simply because we're going over it. You guys out there in the field, we don't run enough calls to have this down pat. Usually what we say is, oh shit, they look bad, call a helicopter. Or, oh, that car looks really bad and they look like they could be bad, call a helicopter. And I'm completely fine with that. I think for the most part, we could always justify what we did whenever we err in favor of the patient. Whereas vice versa, if let's say our 4-wheeler accident we had out here, we're like, we'll just take them in. And I guess she had some pretty bad cuts on her head. Yeah, but let's take her in. Surely it's not that bad. And then she has these bleeds. We'd have a hard time justifying what we did. Now, she's obviously a priority 1 because she's unconscious. So
Yeah, she was on.
Yeah. So anyway, let's go over priority 2 criteria. Now, priority 2 is prompt transport to the designated level 3 trauma center or higher, depending on location, according to the regional trauma plan. Any idea where our local level 3 is? No?
Anywhere?
Enid.
Enid?
Yeah. All the hospitals out here are level 4. I want Phil to I don't know if I'll have him do it during a refresher or sometime before I leave, but I'd like for Phil to come talk about the CT scanner. Because there are times where we bypass. Now there's times where we're told to bypass because we're doctors are brilliant. Anyway, we're told to bypass. That's not something we do, but we shouldn't bypass because we think hospital C down the road has higher capability. We're all level 4s, and actually the CT scanner in here is one of the best CT scanners in the nation. So they can diagnose these patients just as well as anybody, and they're getting ready to get a ultrasound here. So not only do they have a CT, but they'll be able to do ultrasound to see bleeds. So don't hesitate passing by here. Now, obviously, if one of our great doctors, one in particular, tells you to go on, you know what, go on and let either the EMS director know, whoever it is at the time, pass that information on, because they cannot divert you. We're an ambulance, they're a higher level of care, they're a hospital, they cannot divert us, and they're going to get an EMTALA violation for that. Correct?
The Oak City ER physician was not happy and called them.
Yeah. Yeah. So.
Not at the ambulance.
Yeah. No.
You know, they're told, well, you can fight it, but you know what I mean. Like, you really should just do it yourself, and then let the hospitals deal with that side of it. That way we're not.
I don't expect you guys to get in a fight on the radio, but I do want you to know that if you have an issue that you believe you can't handle from here to Elk City, you need to stop here. No matter what they're saying, you need to stop here, because this is a hospital and they should have equipment and ability to take care of that patient. Really stabilizing blood, IVs, airway. They should be able to do those things. I'm not saying they're going to be able to do it, but you know what?
they're either going to die in here from you doing the right thing, or they're going to die in between here and there, you're doing the wrong thing. Now, which way is more defensible? Stopping here, because they should be able to handle it here. A lot of times there's somebody around. Sabrina might be around. Sometimes I'm around. Dustin's around. Somebody that's perfectly comfortable handling an airway or something. So, and a lot of times, even though maybe we don't get on the radio, we are listening. So if we're close, we will come help. Not me though. I'll get a few more days.
We're gonna show up at the Pandora.
What's that?
You're there.
We'll come find you.
Bring the patient to Edward Jones' office.
Yeah.
So anyway, let's go over the priority 2. Understand that basically out here, and this is something that the state has a hard time understanding, no matter how many times we go to the stupid RTAB meetings. Our closest level 3 is Enid. Yeah, so we're closer to just go to Oklahoma City from here. It's further to go to Enid than it is to go to Oklahoma City. So all of our patients were sent into the city, whatever. So here are your level 2. So patient with potentially time-sensitive injuries due to high-energy event, positive mechanism injury, or with a less severe single-system injury, but currently with no physiological abnormalities or significant anatomical injury. So ejection of the patient from an enclosed vehicle. So basically, if you have a patient who's ejected, even when they're talking to you, you should at least try to talk them in to going, getting on the helicopter. We're going to go call a helicopter for you. No, I don't want to do that. I just want to go, sir, you know, try to talk them into it. But if they're adamant about it, they can make that choice if they're upright mind. Now, if they're confused, they can't. So, auto pedestrian or any auto bike or motorcycle crash with significant impact greater than 20 miles per hour with the patient thrown or run over by a vehicle. So, most of the time, those go beyond your priority 2 patients. Most times, they're going to be priority 1 anyway. Falls greater than 20 feet or distance 2 to 3 times the height of the patient. I say be careful with that. If you have a patient laying on the ground that is unconscious and they only fell 6 feet, that's a priority 1 patient. All right. So I learned something new just by reading an article the other day, but motorcycle helmets are tested at 13.4 miles per hour. Why? Well, because that's a terminal velocity from dropping that helmet at 6 foot. That helmet's not going to get any faster whenever you drop it. So that helmet is designed to protect you at 6 foot. So if somebody falls on their head from 6 foot, that's a significant amount of injury. So imagine your people out there that fell on the pavement on their motorcycle and opened up their head and they have a head injury. Most time, what did that was that not this direction, but the down direction from the 6 foot area down to the ground without having anything break that. So kind of something I always like to say is, you know, treat your patient, treat the thing with hair, not the algorithm or the monitor. If they're presenting in a way that says this is a priority 1 patient, then make them a priority 1 patient. Well, it wasn't 3 times their height. We're going to take them into a local hospital, yet they have CSF coming out of their ears. So hiring, that's covered in the other things. There's physiological changes that would make it a priority 1. But significant assault or altercations, high risk auto crash, neurology, so head trauma, loss of consciousness, or altered mental status, but currently alert oriented. So you have somebody with a positive change in LOC. So the passenger says, no, they were unconscious for a good 2 minutes. Or sometimes we get the fire department and say, you know, when we were sheriff's department, when we got here, they're unconscious. That patient is now a priority 2 patient, even though they're like, oh no, I'm fine, I'm fine. Now they can make that decision to refuse, as long as they're ANO times 4 at the time. But one thing that I'd make sure you do is try not to release them to themselves. You know, hey, we need somebody to come. You know, you've lost consciousness. This could be a serious injury. I don't feel comfortable just leaving you here by yourself. And so Same thing up there. So orthopedic, single proximal and distal extremity fractures, including open from high energy event, isolated joint dislocation, knee, hip, elbow, shoulder, without neurovascular deficit, and unstable joint ligament injuries without neurovascular deficit. So if they had a car wreck, Dustin didn't break his leg, did he? On that one. But let's say they have a car wreck and their ankle turns over and breaks. That broke their ankle on a high energy event. They're now a Party 2 patient. And then they got maxillofacial trauma. So facial lacerations such as those requiring surgical repair, isolated open facial fractures, or isolated orbital trauma with or without entrapments or avulsed teeth. That doesn't sound very comfortable anyway. So those are your Party 2 patients. So what you're gonna do with those is send to nearest level 3, but actually it's closest level 1 or 2 for us. So, once again, kind of like everything else we talked about, if your patient, continually monitor your patient. If they can change, they go from a Party 1 to a Party 2. All of a sudden you have the blood pressure drops, heart rate goes up, and you see signs of shock. This patient's now become a Priority 1 patient. You want to maybe change what you're going to do at that point. All right. Any questions? You guys want to call it? Anybody want to talk about anything?
Good.
Good.
I'm good. Looks like Kim ditched us. Dang it, Kim, you ditched us. Oh well. I'm done, because this is kind of what I plan on doing for the refresher. Not this, but just kind of talk about the topics that we're supposed to, and then move on. I probably will not stay here till 10 o'clock every night. If we have a good night of discussion, 8. All right. Shouldn't say that on a recorded thing, but I don't really care. I'm done January 16th. All right. Well, I'm done.
Cool.
He's done.
Have
Next
fun.
Wednesday?
Next Tuesday. Wednesday.
Tuesday, Wednesday.
Yeah.
Okay.
And if you can't make it, I'm not going to throw a big fit about it. Just tell me that you did it on the YouTube. Just tell me you watched it on the YouTube.
Be here.
I won't.